His work, in the development of techniques for the treatment of intracranial aneurysm and brain AVMs contributed to the endovascular development in the cure of this lesion. In addition of this aspect, the contribution to the training of numerous professionals who currently practice their activities in Brazil. Another important contribution of their continuous help is in the development of a professional in the area with, for example, link symposium and the presence at events of which I have invited him numerous times. Today, we will have the opportunity to receive new information and emphasize others that will certainly help us in our daily activity. Thanks for everything. Welcome, Jack.
Thank you, Jose. Everybody is hearing me?
Yes, Professor. Perfect.
Okay, wonderful, wonderful. So, I don't know if this is exactly what you're expecting, but this is what I'm going to present you. It's an experience on aneurysm treatment and evolution of aneurysm treatment during the last 10 years. But it's also philosophical thinking and ethical thinking about what we do. And I think it's important because probably most of you know that there is not that much improvement, technically speaking, in the treatment of aneurysm for the last 6-7 years. The last new evolution was the endosaccular device, like the web, but it's already more than 7 years, so it's not that new anymore. And for 7 years, we have exactly the same way of doing and the same way of treating, except the fact that probably we are thinking more and more about, is it right what we do? And I think that we definitely have to ask us this question, is it right what we do? And more or less, I'm going to combine in this presentation the ethical concern and technical concern at the same time. So this is a place I am working in Bisset Hospital. It's an hospital which was built up in 1750, around 1750, and the department is located at this level. This is all the angio suites, and here is the office of the medical doctor. And here is the rooms, the wards where the patients are hospitalized. So it's a well concentrated and independent unit. Inside, of course, it's not that old. It's extremely well equipped. We have a wonderful biplane equipment, both sides, 2 rooms only dedicated to endovascular treatment. And this is a team working with me. So everybody is involved in the development of this department. So now let me go more deep inside the presentation, which is past and future of aneurysm. So I'm not speaking about ruptured aneurysm. There is no real debate about ruptured aneurysm. You have to treat the ruptured aneurysm because the risk of rebleeding is very well known, about 50% during the first week after the first bleeding. So no question about ruptured aneurysm. The concern is why and when should we treat incidental aneurysm? And this is the very, very important question because for the time being, nobody knows. The natural history of aneurysm is more or less known, but I'm not so sure that it's perfectly known. And the impact on whatever treatment is not definitely known because there is no real randomized studies that have been done in the literature. So all we know basically on ruptured intracranial aneurysm is a result of the Ushuaia study where there were two groups. The patient who had no history of subarachnoid hemorrhage from any aneurysm, this was group 1, and the patient who had already bleeding from an aneurysm and who present with other aneurysm that have not bled. So it's a way to compare a population of patients which has one aneurysm, and we follow. And the other thing is you follow a population of patients which has multiple aneurysm, and according to me, it's a completely different song. There is no way to compare the first group and the second group, but this is exactly what has been done in the Ushuaia. So what do we learn from Ushuaia? It's basically the rate of bleeding in the group 1 cumulative rupture rate is around 0.05% per year. And in the group 2, where the patient had presented with already one aneurysm with a bleeding, the other with no bleeding, the risk of rebleeding, the potential risk of rebleeding is about 11 times higher, which is 0.5% per year. So overall, the risk is definitely not high, despite the fact that I disagree with this population of two groups, because my philosophy is I think that the multiple aneurysm, it's a different disease. And we all know that, because if you look at the literature, the treatment, whatever the treatment, surgical or endovascular treatment, is much better in multiple aneurysm compared to single aneurysm population. So let's have a look at all those data, because there is no other one to really take care of account. So basically, if you mix all together, we can estimate that up to 10 millimeter, the risk of rebleeding is about 1% per year. So this is, including both groups. So it's not high. So each time you propose a treatment to a patient for an aneurysm which has not ruptured, you have to be concentrated about the fact that your treatment should be not more than 1%. And that's extremely difficult to tell honestly to the patient, because nobody knows. You probably remember that there was a potential randomized study whose name was TEAM study, but the study was aborted because it was not possible to recruit the patient. And the very simple thing is because when the patient has an asymptomatic aneurysm, the first time he got in contact with this aneurysm is the comment or the report of the neuroradiologist looking at the CT scan of the MR and saying, oh, guys, we discovered an aneurysm. You have to go in emergency to see a neurosurgeon because it's a bomb in your head. So how can you move back and re-enter the patient in a randomized study when the patient knows already that he has a bomb in the head? And that's exactly the problem we have been facing. I have been participating to the TEAM study, and we had this concern. The patient, they really didn't want to participate in a randomized study because they knew from the beginning that they had a bomb in their head. It's like the COVID vaccine, saying that it's extremely difficult to rub out of the brain of the people. So in absence of scientific criteria, your decision is only based on your soul and your consciousness. And that's a big concern. You are a neurosurgeon, you are an endovascular, you are doing both at the same time. Whatever the treatment you propose to the patient, you decide according to your soul and your consciousness. So the only criteria is basically your own ethic. Own ethic, it's a nice word. But look at humanity. Now, what is the definition of ethics? Ethics is the science of moral and lifestyle. Okay, why not? Which is an essential and specific criteria of human species. There is no question that we are the only species on this earth having this, science of ethics. So ethics is related to the value of a given human community. Ethics in a given community is completely different to ethics in another community. And you all know that. If you look at the news, there is no question. We have different ethics depending on where you are born and which community you belong to. So for that reason, ethics vary with the community. On the contrary, to the moral. The moral is universal, eternal, and the character cannot be discussed. So there is a big difference between ethics and moral. We don't treat aneurysm according to our moral. We treat aneurysm according to our ethic because we have no randomized study. So the moral is what you do by duty. And this is a philosophical concept which is perfectly admitted all around the world. And the ethic is what you do with your sentiment, your feeling, your emotion. It's a mixture of your skill, your past history, and the way you analyze yourself outside of all kind of data and randomized study. So keep that in mind. It's extremely important. The real concern is to practice moral and ethics. You need to be a human. We are human. And humans have a highly developed brain capable of abstract reasoning, language, introspection, problem solving. Humans become ethical person because persona means mask in Latin. So when you put your mask of human, you become an ethical person. When in addition to that, previously characteristic, you have your self-awareness, you have some rationality, some sapiences, some wisdom, and judgment for the best of the other human. And this is the key point. Ethics should lead to a solution, a comment, an action, a treatment, which is for the best of other human. So let me be a little bit skeptical about this. Human can be extremely good and extremely brilliant and extremely ethical, like those two guys, Einstein and Pasteur. But those two guys are human too, and they can be incredibly bad and detrimental. So, you know, your ethics has a lot of different bias, and that's the reason why each time you speak to somebody, when another doctor speaks to him and gives a different kind of advice or opinion, they have both the same weight. So the only solution for the patient is to trust the people you speak with. So this is your own way to present yourself to the patient who takes the decision to do or not to do the treatment. And this is unbelievable for me in a science concern. So human approach of patients, it's extremely important. And being as ethical as possible is to give the advice and the treatment the best for the other human, okay? But it's not only you. It applies for doctors to the patient. It applies for doctors versus companies and vice versa. And it applies for companies versus patients. So many different parameters have an action on the decision you take, you propose, and on the fact that the patient is accepting or not. So having said that, we definitely have to be convinced that we don't do a treatment just because we have the technology to do it. We do a treatment because we are medical doctor and we work in a human approach, which is as ethical as possible. If you keep on following this, you are very critical about what you do. Despite saying you have an aneurysm, I do a treatment, that's not true. You have an aneurysm, sir or madam, because it's more frequent in the female. I will do this because of this, because of that, because of my feeling, because of my experience, because of my own perception, because of my own perception. Very important. Now, the treatment is ethically covered. You have the umbrella, and then it's a mixture of strategy, concept, and technique. Okay. The problem is you have to be concerned that there is no single way of thinking, way of doing it, because it's always moving. And the paradigm in science is extremely important. The paradigm in science is universally recognized scientifically achievement that for a time provides a model of problem solution for a community of practitioners. So today, on October 2021, we have some paradigm for building a kind of strategy for the treatment. But those paradigms are supposed to change. Those paradigms will change Those paradigms probably, if you don't follow too much, are not exactly updated. So we have to clearly understand that the paradigm is true for a period of time, and it's completely wrong maybe for another period of time. Look at this. The paradigm has to shift. They shift because it's by their own, I would say, gene. The gene of a paradigm is to move according to the evolution of science. Look at what has happened to the Newtonian mechanics. It has moved to the theory of relativity, which is completely different because it does apply for nanoscopic matter. Aneurysm coiling packing has completely changed the paradigm of treatment towards a flow diversion. So you have to be completely concentrated on the fact that all what you think today are probably wrong in 1 year, in 2 years, in 10 years. But be conscious that nothing belongs to real truth. The truth is suspended in time, and you play with your knowledge at the time you have with your experience too. So you have also another concern, which is the paradigm paralysis, which is the inability or the refusal to see beyond the current model of thinking. There is a lot of people that refuse to use flow diverter. There is a lot of people that refuse to use balloon remodeling or stenting of an aneurysm. Why? Do they have specific data to think so? No. So this is the paradigm paralysis. And I know a lot of people that are paralyzed because they don't think about the fact that the paradigm can shift. But now there is another, which is the contrary, which is a paradigm optimism. Each time something is new, it's good. This is a new thing. This is the one that you should do. You should use. This is the one you should propose to the patient. And this is the treatment we will do. But which is based on what? Which is based on nothing. We don't know. So do we speak with the patient? We don't know, and we will try to do something on you with this new device? No. So we have to be always balancing between our knowledge, our experience, the possibility and understanding the new devices, and overhaul in the ethic environment. So let's have a look at this, because this is a summary of all what I say. The tools and gadgets. I say we have tools and we have gadgets, which is evolution or confusion. Sometimes the evolution is so quick and evolution is so diverse that we are a little bit confused. This is the evolution of all kinds of material we have been using from the beginning. The coil, the balloon, the stainless steel stent, which is the laser cut stent, the braided stent with coil, the flow diverter, the coil plus flow diverter plus stent, the endosaccular device, the contour, the balloon plus stent plus endosaccular device, the coil plus piconus, which is another kind of system which is supposed to hold the coils in the sac of the aneurysm, on the pulse rider, on the eclipse. Who knows? Who knows what to use? It's extremely difficult. Now nobody knows, so let's play and see what has happened. Because time is eliminating progressively all what is useless. So let's have a look at the parent vessel artery. We have been doing a lot of parent vessel occlusion, and it was a very good way to treat an aneurysm. But this is completely obsolete at the same time as the balloon selective occlusion. I was one of the 2 people in the world doing treatment of aneurysm with balloon, but I did understand that the coils were much better. So I had to completely abandon the balloon occlusion. I'm not speaking of the balloon remodeling. I'm speaking of balloon treatment, selective treatment of aneurysm in 1982. So this is obsolete. At least parent vessel occlusion, we still have indication for parent vessel occlusion. For the rest, coil selective occlusion, self-expandable laser cut stent, self-expandable braided stent. This is the evolution, 91, 23, 23, 26, a flow diverter, endosaccular device, blah, blah, blah. This is the kind of tool that we are using every day, and I would say this is the mature tool, And the one that are under evolution, which is the one on the last page, which is the contour. Now, if you look at what has happened to this, let me show you what has happened. We have 0 comparative study to evaluate the result of all those different ways of treating endovascularly an aneurysm. 0. Do you think it's normal? If you look at the next one, which is under evaluation, I'll bet with you that it will be exactly the same. We will never have a comparison study to evaluate the result, for example, between the web and the contour. Nobody will put the money on that. The authority and the public system will not put the money because they don't have the money to do it and because they don't care about this. It's absolutely incredible. And the company, they will not put the money on the study, which might probably end with a bad result for their own device. So forget, we will never know. So we have to play with our own ethics and understanding. Honestly, and I am very polite, it is to the minimum a pity. It is a pity. Now, the paradigm which are shifting are depending on clinics, anatomy, and techniques, and okay. So we still continue to use a lot of tools that are already old, but they are not dead. The coil is not dead. We started using it in 1993, 28 years ago, but we still use it, and it's still very useful, and it still gives a lot of good results, and it saves a lot of life and gives good results on a long-term basis. So the only paradigm that are completely shift and replace the old one is the paradigm which is linked with the imaging. Nobody is using the film anymore. Everybody is using the digital, and everybody has this real-time subtraction, and everybody has now the CT scan in the angio suite. So this is the only example in our field that a paradigm has completely replaced the old one 100%. For the rest, all the devices, we still are using the devices that you have been using for 28 years. Aneurysm concept shift. We also have to be concentrated on the fact that everything is moving. Surgery versus endovascular, deconstruction versus reconstruction, coil packing versus flow diverter versus flow disruption, and also the medical treatment to accompany those treatment, which is basically the anti-aggregant treatment, and we have switched from the clopidogrel to the ticagrelor to the prasugrel to the cangrelor to the elinogrel. So this is always in movement. Surgery versus endovascular. Yes, finished. If you want to discuss that, just do another randomized study and then we discuss. Otherwise, you cannot argue. ISAT has clearly demonstrated that there is definitely an advantage for the patient to get a treatment by an endovascular way. And this was done in 2002. I mean, the end of the study, it started in 1997. So it's a 5-year study done 19 years ago. Imagine how much we have improved all this time. From the first case of the study to now, it's 25 years. The endovascular treatment is completely different. We have so many tools and so many ways to treat an aneurysm today. Look at that coil alone, coil balloon stent, flow diverter, in and out is the disruption of the flow. So it's an incredible evolution. On the contrary, the clips has not changed, except the fact that for at least 10 years or 15 years, you have the ICG in the operating theater, which is very useful, but the clip is a clip, and that's it. You need a good training, you put your clip, and that's it. There is not that much evolution. So we cannot compare a study now and the treatment we do, because the study ISAT has been done such a long time ago. If we repeat the study today, the result will be much better in favor of endovascular, because we have improved dramatically. There is no question about it. So these are the different results about the cognitive and the epilepsy and blah, blah. I'm not going to speak about that because this is not really the problem. The problem is, if you want to debate and to argue against ISAT, do another randomized study and let's discuss afterwards. So this is the final result. So there is no question. Endovascular is giving a better result for the patient. And if we redo the study today, I bet with you, the result will not be better. It will be much, much more better. So that's it. This is also the Barrow, the Brad studies that confirm exactly the same. Okay. So why do we keep on debating endovascular versus neurosurgical treatment? I don't know. Honestly, I don't know. I don't care if you want to stop doing endovascular treatment. This is your own decision. But if you want to argue scientifically speaking, there is no reason to keep on debating on this subject because the story is finished. So surgery versus endovascular, finished, endovascular won the battle. And there is a very good sign about that. All the neurosurgeons are now doing endovascular, and I think this is extremely good. It is extremely good. Why? Because you manage your disease, you manage the patient, you manage the treatment, and if you need to do an external shunt, and if you need to remove an hematoma, you can do it at the same time. I do advocate, I am 100% convinced that this treatment has to be done in a neurosurgical environment, no question about it, but think that clipping aneurysm is finished. Now, deconstruction versus reconstruction. Let's have a look at what we were doing. In this cavernous sinus aneurysm, 25 years ago, the only thing we could do is to occlude the parent artery. And it works. If you look at the evolution of this patient, it's a young kid. This is several months later. Aneurysm is completely gone. Of course, she lost the carotid artery, but she's completely cured and she has a fantastic result. Now, if you want to play with the occlusion site, it's very, very useful too. If you want to bring the water to this tower and to bring the water to this single flat house, it's a completely different song. And this is what you can imagine when you reverse the flow at the level you choose, not at the level you can, at the level you choose. If you put a balloon here, you have an inversion of the flow by sucking effect vacuum territory of the ICA. If you put the balloon here or whatever to occlude the parent artery, you had also the pica territory. So when you play with the vacuum territory, you can suck more or less, and the goal is to reduce the territory you have to supply, and by reduction of the territory, you reduce the pipe. This is absolutely true. There is no other option. If you reduce the volume, you reduce the pipe. And by reducing the pipe, the aneurysm is disappearing. This is what we have been doing 20 years ago. This patient had a huge giant aneurysm of the basilar. What did we do? We just checked the potential collateral flow. There is a PCOM here. Depending on where you occlude, either here or here at the level of the pica, you change the vacuum territory. So at that time, it was difficult to choose. So we did a balloon test occlusion, and we noticed that there was a reversal of the flow by the action of the vacuum territory of the pica on that side. So following this balloon test occlusion, this is what we did. We put a little bit of coils to avoid as much as possible the release of the protease, the proteolytic enzyme. And after understanding where we can occlude, we did the final occlusion by delivering coils at the place the balloon was giving us the location. And this is the final result. And as you can see, by the reduction of the territory of the basilar, which is now just supplying the pica on the other side, the aneurysm has completely gone and the basilar artery has been reconstructed. So it works, and there is no possibility for this patient to recur, and you don't need to leave the patient under double antiplatelets, but nobody does that anymore. If you had such a giant serpentine aneurysm of the ACOM system, today probably everybody will try to put flow diverter or any kind of other stent to treat this patient. But there is no question that this is still a good indication for the treatment by parent vessel artery occlusion. You test occlusion with a balloon, you analyze the potential collateral circulation, and when you know that there is a collateral circulation or the anterior circulation, you just occlude. This is after the occlusion, this is before the occlusion. You have the collateral circulation you were expecting, the patient is cured, aneurysm is shrinking, and there is no side effect of that. So this is another case where I would do the same treatment as I did 20 years ago, which is occlusion of the parent artery, because where do you place your stent? Where do you place your occlusion? How do you analyze this to save and cure the patient properly, understanding that the superior cerebral artery on that side is also involved in the dissection process. So there is no question that the dissection process is responsible of the aneurysm. And as far as the patient has no clinical sign related to the dissection and the aneurysm has been discovered incidentally, the only good reason to treat this aneurysm and the only good way and ethical way to treat this aneurysm is just to occlude the sac itself, because the sac is the place which is the safest place. As far as the dissection has not produced any side effect on the perforators, it means that there is no perforator in the dissection, so just occlude the sac. We did occlude the sac and exclusively the sac. This is a control angiogram. Of course, it's not that spectacular if you compare with the remodeling of the vessel and the reperfusion and the parent artery, but it is extremely efficient with no risk of recanalization, and this patient is cured. Now, I want to introduce a concept which is not really discussed in all the congresses and meetings that we have all together. This is a concept of the new anatomy. Let me show you this patient who was treated in 1990. At that time, we were doing the balloon test occlusion and the occlusion of the aneurysm, selective occlusion of the aneurysm with a balloon, detachable balloon that were inflated with a polymerizing substance whose name was HEMA. So this patient was treated with a balloon, and after the positioning, the HEMA was introduced, the HEMA was checked, and when the HEMA was hard, you detach the balloon, and this is the final result. There is a little bit of, passage of the dye around the balloon after the treatment, but this is the result that we got. Now, let's have a look at the control angiogram. This is July 19, and this is February 91, so less than 1 year. There is the aneurysm, which is completely gone, but the base of the aneurysm itself is still visible. So how do you analyze this? We don't know. So we did another control angiogram in October 91. Then we did another control angiogram in 2000. Then another control angiogram in 2002. And as you can see, it doesn't change. It's even a little bit less, let's compare. So we continue to control, and we did another one in 2015, which is 18 years later. And as you can see, it doesn't change. So is this aneurysm a danger for the patient? Is it an aneurysm? Or is it just a new anatomy after the exclusion of the aneurysm itself? This is what it was before. And there is no question that we have to change our mind. We are not here to do cosmetic repair of the parent artery. We are here to avoid an aneurysm to bleed, and we are here to avoid recurrences potentially on a long time and rebleeding on a long time. That's it. But when you have this, which is perfectly stable after 18 years, I really don't think that there is no reason, for example, to put a flow diverter now, because this patient doesn't complain with anything. And for me, he has a new anatomy and it's perfectly secure. So this concept of new anatomy has really to be debated. And I would love to debate it with all the community, including the neurologist and everybody. So let's continue with all what we do today. It's extremely wide, it's extremely extensive, it's extremely variable. Everybody does what he wants, and you cannot argue because everybody has the right to do it. You have this aneurysm, after bleeding, you can clip the aneurysm. If you think that this is the way to do it, you can remove the hematoma at the same time, clip this aneurysm. We didn't do that. We angioplasty the vasospasm with the balloon. We place the balloon at the neck, we put some coils, and then we got this after the treatment. We didn't try to remove the hematoma, and this is more and more common now. We don't jump on the hematoma as we were doing before, and this is a good way to do the treatment. So I respect clipping this aneurysm, but I respect endovascular treatment, and this was a good way to treat, and today I would do the same. 25, 28, 30 years later, balloon and coils is a good way to treat the aneurysm. When you have this specific anatomy with that tiny aneurysm in the ampular division, which is a variation of the anatomy of this basilar division, this is what we have. How do you do that? Now, 24 years after the treatment of this aneurysm, how would you manage this patient? Exactly the same way. Exactly the same way. Look at that. We place a balloon in the dilatation of the basilar tip. we placed the coils and we got this treatment with a wonderful result. Today, I would do the same, except that I don't have this balloon anymore. The latex balloon, round latex balloon are no more available. They are forbidden. You won't find anyone on the market. So how do you do that? Now it's going to be very difficult to treat this aneurysm. Very difficult because you don't have this balloon. I even don't know how I would do the treatment of this aneurysm today. Honestly, I don't know. So this is a problem. You know, some of those tools were very useful and we don't have it anymore. Nevertheless, let's have a look at this aneurysm. You know, whatever the timing, I will do the same. Is there another way to treat this aneurysm by an endovascular way, except the one that we have been using there? So we just navigated and we used our understanding of the difficulty to do the treatment endovascularly. It's a very acute angle of one of these double ICA. But the problem is, we know that the catheterization is going to be difficult. So if you look at the anatomy of this patient, you can clearly see that here there is a pickle. If you come from above, it's much easier because there is no angulation here. So this is exactly what we did. And today I would do the same. We have different tools, but I would use coils and would use a catheter and I would use the same approach. So there is no question that it has changed, but it has not changed completely. This aneurysm today, I would do the treatment the same. Look at that. You have now a concern with the neck and the patency of this ICA. Okay, let's take the risk. Let's take the risk. How can you manage it? If you want to clip it, you will get a complete occlusion. So what we decided to do, we decided to pack the aneurysm, come in from the PCOM, delivering coils in the sac of the aneurysm without taking care of the potential patency of the ICA. At the end of the treatment, this is what we got. We were 100% sure that this aneurysm would cure and the parent artery will be occluded, but this was a bet. It's much better to have potential deafness on that side than rebleeding and dying from this aneurysm. So it was, in agreement with the patient, and this is what we did. Now let's have a look at the control angiogram 9 months later. The parent artery is patent, aneurysm is gone. We are not expecting the parent artery patent, but we got it. There is some uncertainty. We were all thinking that this parent artery would occlude. It didn't. Why? I don't know, but this is a fact. So today, I would do exactly the same treatment, not because of this good result, but because I have no other way to do it. Exactly the same for this patient. Look at this patient. He has a blister-like aneurysm at the basilar division. How can you manage this blister-like aneurysm today? With the same. We put 2 balloons, kissing balloon to protect the neck, to put coil in the middle, and to finally exclude this aneurysm. How can you do that today? You put a flow diverter here, but you keep on having this aneurysm patent for a while. It's a blister-like. The risk of rebleeding is extremely important. I would do the same today. So nothing has changed in a given part of the population. This aneurysm, middle cerebral artery, no question, it can be clipped. I am not arguing that the fact it can be clipped, but there is no question that endovascular, statistically speaking, give a better long-term result for the patient and his clinical condition. I forget about the potential long-term follow-up of the anatomy, because there is a new anatomy, which is a concept that is definitely something that is true for us. So when we do the treatment of this aneurysm, this is what we did at that time. We have been using a round balloon at the neck and put the coil in around the balloon and get a complete occlusion with a patent preservation of the patency of the branch of the bifurcation. It's a very elegant way to do it. And today, if I had to do it, I would be a little bit in trouble because I don't have this balloon anymore. You can put a flow diverter, but a flow diverter in a bifurcation, it's not that simple. Technically, it's a piece of cake, but the concept is the branch which is covered has a high tendency to occlude, and if it happens too rapidly, then you get a clot and you get a complication in the territory. So there are many things that you can manage. In this situation, we didn't manage anything and we got a very good treatment. Exactly the same with this patient. The round balloon at the bifurcation here is giving a very good result. And the advantage of this is at the time it's implanted in the bifurcation, it never occludes completely the flow. And that's good because even if you leave it, 45 minutes, as far as there is still some flow going around the balloon, the patient will not stroke. And that's a tremendous advantage, but we cannot do it anymore. So for those patients, despite that we have no more round balloon to put the coils, we have to use a different tool. So the elimination of some of the tools we had are pushing us to use a different tool to do the treatment. This is a recurrent aneurysm after clipping. I don't do that because I want to show you that there are recurrences after clipping, there are recurrences after clipping, there are recurrences after coiling and whatever the treatment you do by endovascular. The problem is not there. But this patient, if I had to do it today, I would have to put either a flow diverter or a Y stenting. And honestly, it was that simple to do it with a round balloon and to get this wonderful result. Unfortunately, we don't have it anymore. So we are putting all those material in the parent artery. Do you love or would you love to have this Y stenting in your parent artery, in your middle cerebral artery? You. I'm not so sure. It's quite a bit of material, despite the fact that the results on a long-term basis are extremely good, despite the fact that complications are low, but I'm not happy to have this material in my middle cerebral territory. The result is wonderful, but we don't have any other option for that, except you put an endovascular device. Now, it's good. Evolution has given us the possibility to do the treatment with an endovascular device. But the endovascular device has also is a limitation, and you will see that it has some limitation. So there is definitely a thing that we have to be concentrated on when we do it. We never get 100% of the truth. We are proposing what we think is the best, but it's not necessarily the treatment that the patient should get, unfortunately. But this is a reality. And having those two Y stenting in the parent artery, it's good because you have a wonderful result, as you can see here. This is October 2012, which is almost, when was that done? I don't have the date of this. It was 9 months later. You have this wonderful result, as you can see here, October 2012. But when the patient came back in April 2013 with a wonderful result, she was complaining with a mild deficit of the upper limb. And the reason is that it has, this little stroke here. So more than 2 years after the treatment, there was no more double antiplatelets treatment given. The patient got a stroke because of this foreign material inside the parent artery. We should never forget this. And if you look at the VASO-CT, which is analyzing the architecture of the stent, you can clearly see that there is a kind of destruction of the stent, which is definitely responsible of the potential clotting. So there is no question that it's not trivial to deliver a Y stenting. In this case, it was absolutely the way to do it. Today, I would not use a flow diverter. I would keep on using the Y stenting, and probably I would keep on using the laser cut stent, one with open cell, one with closed cell, because the open cell is bulging in the aneurysm. And this is exactly what we need. This is the immediate post, and this is 8 months later. Think about this incredible result. Let's have a look back to what it was. How can you manage this aneurysm differently? It was a very right way to do it, and I would do the same today. No question about that. And this is this wonderful result. This is another large aneurysm, middle cerebral artery. Why do we use braided stent? Because braided stent is so nice. Look at that. They do oppose to the wall of the vessel like crazy. It's wonderful. It's like a sleeve, inside the lumen of the parent artery. So it gives wonderful result, as you can see here. The problem is the braided stent. It's much more difficult to go through. So why don't we take more risk despite using laser cut when we switch to braided stent? Why do we take this potential higher risk just because the picture is better? I don't know. Nobody knows. Nobody knows if the long-term result is better because nobody will get the answer of a true study, which is comparing both way of treating those aneurysms. And we are responsible of that. This is another one. This is another braided stent from the Ball company. It gives wonderful result. I am very happy to show that. Look at how nicely it opposed to the wall of the vessel when you have a section of the material inside the parent artery. Look how nice is the final result several months later. I love that. But going through the stroke of a braided stent is much more difficult compared to going through the stroke of the laser cut stent. On the contrary, the braided stent do oppose nicely and smoothly on the wall, and the risk of getting late complication because of disruption of the architecture of the stent is extremely low compared to the laser cut stent. So we have advantages and disadvantages, and honestly, I cannot give you the answer. Today, I do the treatment according to my own ethics. This kind of treatment gives you the possibility to treat that recurrence. Is it a true indication for retreatment? No. Maybe if I wait for 5 years and the neck is still the same, the patient for me is fine. Why did I decide to do another treatment because of this little remnant at the neck? Maybe the patient has some requirement and he doesn't want to keep on going and having a control angiogram. Maybe, I don't remember, maybe I saw that it was a nice case to do a treatment with a white stenting, but I have no true scientific answer for that. Despite that, I did it. Of course, the patient went perfectly. We have all those nice tools with the braided stent, and we got this wonderful result after that. I am happy with that. But was it reasonable to take this kind of potential complication versus a remnant at the base, which is not that big and probably stable according to time? I don't know. I don't know. This patient in 2003 was treated this way. There is no P1 here. There is no posterior circulation here. The whole P1 posterior circulation is depending on the PCOM, which is giving rise to this aneurysm. You can put a clip, you can put a flow diverter, you can do everything you want. But if you want to do something, you have to preserve the patency of the posterior circulation and the PCOM. So this is what we did. We navigated from the opposite side. We crossed the ECOM just to be sure that we deliver the balloon and have the control of the neck in the proper way. And finally, we coiled and we got this wonderful result. This is July 2003, and this is 2 years later, perfect result and good patency of the posterior circulation. Will it be better to put a flow diverter? Oh, I don't know. Do we take more risk? I don't know. Was it better to do that? I don't know. I did it because I thought it was the way to do it at that time, but the paradigm has shifted. Or maybe the paradigm has not shifted, but I don't know if it has or if it has not. So this is a big concern. I am more and more afraid of the fact that all what we do is based only on our own expertise. It's not really data from science. Flow diverter, what a revolution. The coil is a revolution. The flow diverter is a revolution. This is a principle. You slow down the flow and everything thrombose and disappear, and you get a wonderful parent artery reconstruction. This is the same patient that you saw in the video movie, and this is a perfect reconstruction of the parent artery, and nobody can say that there was an aneurysm here. Wonderful. This is a true revolution. But flow diverter has also some problems. You cannot apply flow diverter everywhere, or you take risks which are not really under your own control. So this kind of aneurysm that was treated 30 years ago by parent artery occlusion, it did not achieve with a perfect occlusion of the aneurysm. So what we did, we asked it for a high flow bypass. High flow bypass, it's finished. We don't do it anymore. We don't need it anymore. This is a high flow bypass that was delivered on this patient. This is a good vascularization of the MCA territory. This is what it was before the bypass. This is what it is from the other side. This is what it is from the bypass side some months later. And you can clearly see that due to the redirection of the flow, nothing else. The aneurysm has disappeared. How can you bet that it will happen? Nobody knows. The patient was very lucky to have this modification of the flow leading to a complete occlusion of the aneurysm. But can you bet on that? No. You cannot. There is no data for that. Today, we would put a flow diverter, like in this patient. This patient has a large aneurysm non-thrombosed with multiple exits from the MCA and the anterior circulation directly from the sac of the aneurysm, as you can see here. So what we did, we bypassed the whole thing and we reconstructed this connection with a flow diverter, as you can see here. And when the flow diverter has been delivered like here, you have this control angiogram, which is performed after the stenting. There is a dramatic shrinkage of the flow in the sac of the aneurysm, as you can see here. And this is the patient which is 1 day post, a little bit of dye, which is still visible. The ACOM is still, the anterior circulation is still visible too. And when you do the control angiogram 3 days later, it's gone. No more aneurysm, no more flow, patient is cured. So this is a wonderful and a tremendous evolution. And I love to do that because it's extremely efficient. All those crazy, stupid aneurysm after very good reconstruction with scaffolding and flow diverter in the middle, you get a wonderful result. This incredible dysplastic dissecting basilar aneurysm can be simply treated with a flow diverter. Everybody knows that. There is no question. Is it better than occluding the parent artery when it's possible? I don't know. I don't know. This patient got double antiplatelets treatment for several months and then aspirin for life. Okay, but could we do the same treatment with parent artery occlusion? We didn't try because we don't do that anymore. Look at this artery, parent vessel dissecting aneurysm. It's incredible. How can you deal with that? You have to repair it. And again, we did exactly the same parent artery reconstruction. We captured the flow of this aneurysm. We even, by precaution, we put some coil in the middle. And finally, you have this wonderful reconstruction of the parent artery. Look at what it is below after the treatment. So there is no question that it's a tremendous evolution. Look at 7 months later, no more aneurysm. Parent artery has been completely reconstructed. Look at this one, exactly the same. This plastic aneurysm, nasty looking daughter sac here, a dangerous one, potentially dangerous one. And this is a simple way to do it. You reconstruct the parent artery with a flow diverter, and you get this wonderful result. So there is no question that I don't argue about using flow diverter in this location, but in some other location, as I showed, there is the debate. I don't know if it's the real way to do the treatment. This one, you can occlude the parent artery if there is an ACOM. Is it better or worse than reconstructing the parent artery with multiple stents and finally having this with a little bit of platelets aggregation of the wall, which is disappearing according to time as far as you keep on going with the double antiplatelets treatment, and you get this extremely good result and reconstruction of the parent artery 18 months later? Yes, it's wonderful, but suppose this patient tolerates the parent artery occlusion, was it not simpler to just occlude the parent artery compared to have this nice reconstruction, but you take the risk of putting multiple stents, having the patient for several months or years with double antiplatelets treatment? I don't know. I even didn't check. I just jumped on the technology we have and I did the treatment with it. Exactly the same for this one. You can do a bypass surgery. You can occlude the parent artery. Why did I decide to go directly for endovascular reconstruction? Because I know what we can do. I know what we can do with the device we have. I know my experience. I know. But what I know is that I can do it. Is it the best for the patient? I don't know. Maybe a bypass and a parent artery occlusion after that would be good. This was done by multiple reconstruction with scaffolding, a 3 flow diverter in the middle of the parent artery. And finally, we got this nice reconstruction of the parent artery, which is 20 months later with the disappearance of the aneurysm and a wonderful result. But all this long treatment took time. I took risk. Was it better to do a bypass and to occlude? I don't know, because bypass surgery has also its own complication. Who is going to give me the answer? Can I rely on the single center statistic? No, we need to have true scientific data to decide, and we will never get it. This is the patient after the treatment. On the contrary, this patient who is 15 years old with this aneurysm, nasty looking dissecting basilar tip aneurysm with all the branches arising from. There is no question that the flow diversion is the way to do it. Of course, you take a little bit of risk. One day pause, the patient got the thrombus of the sac too rapidly, and that's the reason why she got a mild left hemi anesthesia after the treatment. Look at the MR showing this little stroke in the pons. This is one day pause. There is no more aneurysm visible, so we change it. Antiplatelets treatment, and we switch from the clopidogrel to the ticagrelor. So we realized that we were able to reopen the thrombus here, to reopen the superior cerebellar artery, leaving the stent pattern just by moving from the platelets to the ticagrelor. The medication is a tremendous help for us too. We should not forget that the tremendous evolution of the flow diverter is also mainly related to the evolution of the antiplatelets treatment. And this is the same patient. When you look at after the change of the plavix by the ticagrelor, it has been reopened more or less. And this is the evolution of the anatomy. After 5 months, the aneurysm is gone. There is a little bit of bulging here of the parent artery of the superior cerebellar, but aneurysm is gone. The aneurysm is gone. The patient is fine. She has completely recovered this mild hemianesthesia, and she's very happy. And she's 16 years old now. So it was the way to do it, and there is no real other option. So this patient, look at that. Multiple ways to do the treatment. No, either it's parent artery occlusion, very difficult to check if it's possible to occlude because there is no possibility to refill the middle cerebral artery territory, middle cerebral artery territory. But in this condition, you can ask also for a bypass. Why did I decide to take the risk of reconstructing the parent artery from the endovascular, and to do so to avoid this very acute angle from the carotid system? I decided to move from the posterior circulation, crossing the PCOM, and then reconstructed this whole bulge and loopy double lobulus aneurysm, where it's difficult to understand the anatomy. So this is a course of all the reconstruction I was able to do for treating this patient. Look at that. It's 4 different stents in the middle of those arteries with a capture of the dye inside the sac of the aneurysm. This is day 1, almost gone, the aneurysm, and a very nice reconstruction. And this is what you can see after 6 months. The parent artery has been reconstructed, aneurysm is gone. Of course, the patient is lucky. Of course, I am lucky. I could not expect having this wonderful result. I saw that it was possible, but how can I assure the patient that this is what will happen? I don't know. And how can I oppose this treatment to another one? I don't know, because statistically speaking, nobody knows. Even those giant aneurysms now are easy to access. The evolution of the flow diverter is extremely good, because we can navigate with a 17 microcatheter, which is the same catheter as the one we are using for the coils, navigating distally and crossing and bridging the neck of this aneurysm. Today is a piece of cake. It's just a piece of cake. You use a Silk Vista baby. You go through the same catheter, microcatheter, as the one you use for the coil. You deliver your stent. This is what you have here on the vaso-CT, very well positioning and crossing of the neck of the aneurysm. And this is the evolution of the MR. 6 months later, there is no more edema. The aneurysm has started shrinking. And this is no more edema. And this is what you have. The parent artery is reconstructed. There is no more aneurysm. The mass effect will disappear progressively according to time, 6 months later, and the patient is fine. So technology is incredible. And it keeps on going now with this endovascular system, with a well-delineated aneurysm, regular on a bifurcation. You put an endosaccular device, a web inside the sac of the aneurysm. This is what you have when it's delivered. It's a basket to deliver it. Everybody knows that. It's already an old technique, but this is the latest one in the evolution of our discipline. And this is what you have after the treatment. The beauty of that is 18 months later, you don't need to do an angiogram. You just do an angio-MR, and you have a wonderful understanding of the anatomy. You can treat this nasty looking aneurysm with a web. even if the shape of the aneurysm doesn't fit with the shape of the device. This is also something that we learn according to time. We can apply this endosaccular device just in multiple aneurysm, much more than the number of aneurysm that we're expecting at the beginning, because it fits with the neck, and you can forget more or less about the aneurysm itself. Tiny little aneurysm today is just a piece of cake. You do the treatment of those two aneurysms in the same session. Honestly, it takes 30 minutes. It's a young patient. There is no difficulty to catheterize. There is no difficulty to deliver the web. You detach, you get a good treatment. If you want to manipulate the web, you cannot, because you cannot move it per se inside the sac of the aneurysm, but you can switch the web and tilt the web with the balloon. If you leave this corner after the deposition, aneurysm will regrow from this corner. But if you tilt the web with a balloon, like in this condition, the balloon is inflated, you deploy the web, as you can see, you pull on it, you just pull on it like that, and you see that the web is moving back, and the balloon is protecting the patency of the parent artery. And this is what you have after the repositioning of the web with the balloon. There is no more neck remnant, and it's very well visible on the vasosity here. And this is what you have one day post, aneurysm is almost completely gone, which is pretty unusual. And this is what you have 20 months later. So in this nasty looking aneurysm, which was not perfectly fitting with the web shape, you got a wonderful result. Look at that, wonderful result. You can help with a stent if you want. There is no neck here. But if you put a web here and you protect the neck with a stent, you get a wonderful result. This is what has been done. The web was deployed. We didn't want to get the web expulsed in the parent artery after the deployment. So we deliver a stent. The stent was delivered just in the middle. This is after the deployment. There is no risk for the web to be expulsed. This is a laser cut stent, which is not very much thrombogenic. And this is 6 months later. So this nasty no neck aneurysm at the middle cerebral artery bifurcation is more or less easily treated by endovascular way. No question that our possibility today are tremendous, tremendous, even if you want to play in difficult situation and to, like a bailout technique, sometimes you are facing troubles and you need to be able to solve those problems. So this patient was treated with a web. We selected a higher size of the web. We oversized the web to be sure that it was covering the whole neck and getting a good result, because the result on a long-term basis with this device is related to the oversizing. The problem is we had some little bit of a bulging of the web on this corner here at the level of the bifurcation. You can leave it here, you can give the patient double antiplatelet, but you bet that it will go okay for the patient. Betting is not really the way to go. So I think in this situation, it's much better to detach the web. And after detachment, what you can do, you can put a stent. You can put a stent here. So when you put a stent, all what you do is you change the course of the vessel. You don't reintroduce the web in the sac, but you change a little bit the course of the vessel with the constraint of the web, of the stent, and then you have a wonderful result and no risk for the patient. You have complication. We might have complication. It's extremely rare with this endosaccular device, but it won't happen. This is a patient that was treated with the web in emergency. The patient, not in emergency, a cold case, but the web went through the sac itself for some reason. And you can see that at the level of the breech, there is a narrowing of the web because the wall of the sac is up and down. So in this situation, the only thing you should do is to just detach the web. Don't try to remove it and leave it in place so it seals the breech. You have a little bit of leakage, but because of the web inside, you seal the breech and the patient will not keep on bleeding. Of course, then you have to follow. This is the patient a few days after we left and detached the web in the middle of the breech. Of course, there is a remnant of the neck, but this remnant was easily treated with addition of coils at the level of the neck. So, we have multiple ways to escape from difficult situations. It doesn't mean that we escape from all the difficult situations, but we have many, many ways. There is a new endosaccular device whose name is the Contour. It's not really a web, it's half a web. It's a web which is cut in the middle. and it's like a cup that you deliver in the lumen of the vessel. This is one example, a good example with a wide neck aneurysm. You can place the contour in the sac, close to the leg, and now you make it budge, exactly the same concept as the one we use for the web. And this is the long-term result of this patient, just for you to show that there is no more dye coming inside on the control angiogram later on. This is 5 months control angiogram, before, after, very good reconstruction of the neck of the aneurysm with this new device. So honestly, we have so many tools. Sometimes it's confusing, but to finish and to conclude, the COIS was a real breakthrough in 1993. This is like in 1789 when we did the French Revolution. It was a real breakthrough for the French society. Then you have the flow diversion. There is no question that when the flow diversion came in 2008, it was a tremendous evolution. In the middle, you have some improvement. Balloon, self-expandable, laser cut, braided stent, whatever, self-expandable, endosaccular device, web, contour. This is evolution. But the real breakthrough was COIS and flow diversion. And then it's your own perception, your own experience, your own expertise, which makes the decision. So endovascular treatment of cerebral aneurysm seems to have no limit, and there is obviously no limit. So we do apply for all aneurysm. It's safe and fast and much easier compared to what it was at the time of the ISAT study. No question too. We face a big confusion and a big uncertainty regarding which material to use for the best of the patient, because this specific criteria is only depending on you and your own ethic. Thank you.
I think that's it, Professor.
Yes.
Here. So I'd like to open our public over here to I don't know, Dr. Jose Maria. Doctor, if you want to comment.
Thank you, Jack, for the beautiful presentation. I'd like to do the consideration and the one question that you presented for us. It's so wonderful for young people that want to use the modernity because it facilitates your work to the detriment of result. No? All devices remain important. What the question is, what are your ethical and moral consideration in daily practice based on the trials and guidelines? They are general guidelines, or we should follow without distinction. Analysis of each case and the experience of each professional supersede them?
So it's at least two questions. The first one is the models. No question, the model is good. You can get an impression of what's possible to do. But the models, give you sometimes the wrong impression that it is feasible. And in fact, when you fight to treat the aneurysm on a model, the wall of the model doesn't react. The wall of the vessel reacts. You get vasospasm, you get clotting, you get a lot of things. And finally, when you do the treatment on the model and you switch to the regular patient, you might get this overconfidence on your way of treating the aneurysm, and you feel or you face complication that you were not facing with the model, and then you are a little bit lost because you don't know how to manage it. So the model gives you an idea, but I don't think this is the way to train. The way to, it's part of the way, but a small part of the training. The real training is you have a model of the patient you treat. You cannot just treat a model which has nothing to do with the patient you will be treating. If you have the model done with the 3D printer of the same patient that you are going to treat, that it gives you some better impression of what's possible. But if you just treat a model for a model, I think it's an opportunity for the company to capture the attention of the doctors, but I don't think it is that useful. What's really useful is if you train with a given device on a model, which is the model of the patient you are going to treat 2 or 3 days later. That's something which is definitely interesting. The rest is a little bit of music for violin. Guidelines. You can have guidelines if you have data, and without having real data on what we do, it's very difficult. So you can give guidelines on, I would say, sidewall aneurysm and flow diverter versus coiling and balloon remodeling and maybe braided stent or laser cut stent. But officially, there is no real data for that. So the guideline will be, I would say, useful if they are supported by real data, and the real data for the time being, we don't have it. There is not a single study comparing laser cut stent coil, braided stent coils, flow diverter in a sidewall aneurysm. So it's difficult. You have registry, you have a single center publication. At scientifically speaking, it's not the same power as a randomized study. But randomized study is not possible, so we have to play with what we have, and your own experience is good. Having an experience is something. If you are stupid, you don't use your experience. If you do 200 times a mistake and you take it for something true at the end, it's not good. But if you do mistakes and you analyze your mistake and you change your way of doing it, that's good. So experience, expertise is wonderful.
Thank you.
Something about this device, Kankura?
Hi, thank you, Professor Morhe, for the lecture. I would just like to ask, what is your perspective on the use of devices such as Piconus and Picanvas in support of coiling, if they do have a future, or if they are just a passing fad, or if they are a true evolution for the endovascular management of complicated aneurysms?
Those devices came too late. They had something to do with the treatment of aneurysm 15 years ago. Today, I don't think so. We have so many good braided stent, flow diverter, and endosaccular device that honestly, I don't see any future for this kind of device. This is my personal feeling.
Okay, thank you.
It's too late. In the history of treatment, endovascular treatment of aneurysm, it came too late on the market.
We don't have it yet, so we won't use this device. So I think it's fine. I don't know if anybody else has some questions, or I can edit the professor piece here. Okay. So thank you again. So this is the neurovascular course of the Academy of Neurosurgery. I think it's the most important vascular course here in Brazil this year, 2021, sponsored by the Neurological Institute of Curitiba. I want to thank Dr. José for being here with us, Dr. Charles Ramin as well. And we know, Professor Morhe, that you are very busy, but I'd like to say that your presence over here was awfully important. And I hope to see you here again next year in our course. Thank you.
Of course, of course. Okay. Thank you, thank you, thank you. Have a good day. Bye-bye. Bye-bye.
Obrigado a todos. Então, obrigado, Dr. José.
Oh, vamos aí.
Obrigado pela ajuda. Até o próximo módulo, daí vai ser com o senhor, viu?
Ah, ok.
Até 15.